we all know for patients, the advances and the possibilities and the potential of AI are dazzling, and we are very much happy about recent developments. A lot of the patients I know, they use AI themselves. Certainly for the past year, they even have an AI buddy next to them when they go and see the doctors. So it's really something that is changing, revolutionizing, I would say, medicine and care, particularly also the role that patients have as a lay person, but with their AI body, and they become quite dangerous actually. One of my concerns is the database that we're using. So all the data came from somewhere, and it's quite skewed as far as I'm concerned. So I think a lot of the data that we have is based on 19th century. Some of the systems that we use, some of the attitudes that we have in medicine, they really date from previous times, medieval times sometimes. So I really think we need to do some homework, and then I think the potential would be fantastic. Some of the challenges that I saw, particularly complex systemic conditions, we like to have one organ and we focus on one organ, and we don't really, all the interdisciplinary, transdisciplinary cooperation doesn't really work that optimally, and particularly for systemic conditions, that would be key. Certainly from a patient perspective, all the coordination within oncology, that would really be the most important thing to us. And all those chronic, complex conditions, they need answers, and not necessarily only the simple ones. Another challenge I see is that the care pathway that's developed by the institutions is usually very, very different, a complete mismatch with the experience that we have as patients. So on the left-hand side, you see a nice patient pathway, very linear, tack, tack, tack. You get your diagnosis, surgery, blah, then radiotherapy, and then it's done, and you're out of the, you're a survivor, at least you're out of there. On the right-hand side, you see a typical journey, a patient journey with a chronic disease. There's a lot of things going on, and it's only, I think the care pathway is only a very small part of that patient journey. It's much more complex, and some different priorities as well. In Switzerland, we're about 20 years behind when it comes to working with patients, working with citizens, instead of working for them. I think we heard a lot already today what we're doing for the patients, but I think it would be nice to actually talk to them and see what priorities they have. There's a nice little model that has been developed by Canadians to rank the spectrum of how you engage patients, so from a more paternalistic, informing the patients, deciding for them, to actually working with them and deciding, shared decision-making, or even informed decision-making where the patients take the decision. And it's on different levels, so individual level, but also within institutions and research and teaching. And what we want to bring into the discussions, into the healthcare and also the developments of new technologies is really our knowledge, the experimental knowledge that we have, and there's different types of knowledge. We also have some medical knowledge, some academic one, but all the rest is knowledge that patients have, which is really peculiar to us. It's about how our body works, how our body responds to certain drugs, complex or multiple drugs. It's also monitoring how our body works. I'm carrying a monitoring device as we speak now, and all those different types of knowledge need to be acknowledged, and that would reduce this epistemic injustice that we are still living in medicine in many disease areas. I often hear that it's patient-centered and person-centered. It should probably be an advance that we are talking about person-centered, but I mean, it's just quite empty still at the moment, because I don't want to be this, the Sunday roast in the middle of the table, down here, and then you all looking down on me and deciding about me. That would be centered, yeah. We would like to be around that table together and really be at eye level and decide with you. So if tumor board has to be with all the patients, with the patients concerned and the relatives, and perhaps the AI body as well. The gender data gap. I'm a woman. I know that our immune system is very, very different from those of this 70-kilo white male. who's healthy. I'm not healthy, and there's lots of differences, and I'm really concerned that we are missing a lot of the very relevant data on women, also already from the preclinical time, where we use male rodents, healthy young men, then carry on through the clinical stages. And I mean, I always wonder how much that really has to do with me. About over 100,000 publications refer to the use of HeLa cells. HeLa cells are taken from a black woman who not only had cervical cancer, she also had syphilis, for example. And we're basing a lot of our research, at least the research from those times, on her cancer cells. I don't know how much that has to do with the white men here, even the 70-kilo white men in here. So it's really, that is very limited in, I mean, that's what we base a lot of our research on. And I'm concerned that those kind of limitations will be a problem if we don't address them. Medical gaslighting in difficult patients, that's just because I experienced some of that over the past years. I always think medical gaslighting, or if there's some difference between what doctors see in me or think that my problems are and the problems that I experience. So if there's some discrepancy, there's probably something wrong. So the optimal case is really that all your findings, be it with an AI or not, kind of matches my experience, and then there is no problem. But if there is a mismatch, then we will have some medical gaslighting. So I think it's always a sign that something is probably wrong. We have lots of standardized scales. They were validated, but they were validated by some people for a certain type of disease. The criteria was usually defined by the medical faculty and not by the patients. We had no say in a lot of those standardized scales, and I often found now that some of those questions that people asked me, they were wrong. It was the wrong questions, and the kind of answers I wanted to give, they were not really there. So if our data is generated by those standardized scales, which are based on wrong assumptions, then we may have an issue. Priorities are different. I heard some of the talks. I didn't hear all of them, I'm afraid, for health reasons, but I heard some of them, and I heard a lot about mainly quantitative data that is really relevant. Survival time, of course, treatment efficacy and treatment safety. When you talk to patients, it sounds quite different usually. I mean, there's a lot more, there's also symptoms management. I mean, how do you really deal with that? Quality of life. The coordination of the care, those are the things that are really important. Life expectancy is also important, but it's not the first priority. A lot of people would like to die at home, but in the end, they end up dying in the hospital. Those are the kind of things that I would care about as a patient and also as a next of kin, and I did care about. We shouldn't forget the human factor in all of this, really the communication, how you communicate about diagnosis, about the possibilities, about the options that people have, how you really involve them and really respect their needs and their priorities. That is really what is important to us, and it's very much in the background in a lot of cases because we haven't really learned how to communicate and how to interact also with difficult situations. We all agree that we want this comprehensive care at the end of the day, but how we really get there and how we set the priorities is quite different. I see the closing the gaps of those data gaps. That's really an opportunity. I don't think it's a problem. We just need to address them now. And variation. I mean, not being this 70-kilo male. That's good. It's starting to produce data from lots of different people with different races and different genders and sex. That is actually a good thing, and it will make medicine better. We have to respect the needs. Try asking what really matters to those people. Is it really survival time? Then it's fine. But it may not be survival time. It may be quality of life. And the priorities also for services, but for healthcare and research, they should be also defined by the population, by the citizens, and by patients and next of kin. Otherwise, we're going in we have great opportunities. I completely agree, but I wish we could also look at what people really need, and where there's really a medical need that is defined by us and not necessarily all by the professions. And where I see us going is really, I talked to my mother's oncologist, and he felt really threatened by me coming with a pile of publications and also mentioning Dr. Google. He felt threatened by it. He didn't embrace it. So if we already have an issue with that, I don't know how that will work if I come with my AI body, because that's the reality. I think AI will really empower patients. It will empower the next of kin to really, we have the experiential knowledge plus some academic knowledge and a huge field of knowledge really in our mobile phone, and I think it will level the playing field. So I think we will be very much informed patients who want to decide and take responsibility, but also take part actively in the decisions. So I think we are actually very much ready for this transformation, but I'm sometimes not sure my doctors really are, because it will empower us as well, not just you. There we go. Thank you very much.